Good afternoon, everyone. This is Sonia Denisenko, the manager of the Victorian Stroke Clinical Network, and I just wanted to warmly welcome you all to the first Stroke Clinical Network Stroke webinar for 2017. As people are aware, we try and run these webinars on a monthly basis, and today's webinar will be recorded and will be hosted on the Stroke Foundation's Inform Me website in a few days' time. So moving forward, I would like to warmly welcome Sharon Kramer to our webinar this afternoon. Sharon is a PhD student at the Florey Institute of Neuroscience and Mental Health. She has a background in physiotherapy, and she will be concluding her PhD hopefully at the end of this year, 2017. Sharon's special interest is cardiorespiratory fitness early after stroke, and that's the area that she'll be presenting on today. What we would ask is that if you're experiencing any technical difficulties, if you just type that into the blog on the left-hand side, and our technical support people will give you some suggestions and solutions. And also throughout Sharon's presentation, if you have any questions, please type them into the blog, and we'll have about 10 minutes for answering the questions at the end of her presentation. So we won't be pausing for questions throughout to provide answers, but we would like to have a more active discussion and dialogue based on your questions at the conclusion of the presentation. Just a reminder too that at the end of the presentation there's always the opportunity to provide us feedback. That's a really important aspect for the Stroke Clinical Network, so that we can get a better understanding of who's listening to the webinars, what you enjoyed, and how we can do better. And we're always open to suggestions of new speakers and new topics that you would like to hear about. So thanks again, Sharon, for joining us today and for generously giving us your time to provide this presentation on cardiorespiratory fitness early after stroke. Welcome.
Okay, thank you, Sonia, and thank you all for attending this webinar. As Sonia said, I will be talking about my PhD, which is about cardiorespiratory fitness early after stroke. First, I will talk a bit about cardiorespiratory fitness and why it is important in stroke care. Then I will talk a bit about the evidence of cardiorespiratory fitness training or physical fitness training. And then I will talk about my actual PhD projects. So this framework is taken from a Cochrane review of Saunders. The recent update I will discuss in a couple of seconds. But this is a nice framework where you can see that at the top that apart from the risk factors that we know of, like hypertension and physical inactivity, that cardiorespiratory fitness levels and low levels of fitness are also risk factors for stroke. If you then look at stroke survivors, they can experience different impairments. So you can have physical fitness impairments, and in the Saunders review, what they understand about, or what they define as physical fitness, are different things. For example, of what they say is cardiorespiratory fitness is one component, but also muscle strength and muscle power. On the other hand, you can have impairments that are more of a cognitive nature, or things like balance and fatigue. So a combination of these impairments can lead to activity limitations. And you can imagine that activity limitations can lead to physical inactivity and therefore have a detrimental effect on fitness levels. And it also, of course, can have an effect on participation and a restriction in participation. So what about fitness levels after stroke? So this is a graph taken from a systematic review that included 32 studies, in which stroke survivors were tested during a graded exercise test, which gives you a measure of fitness, and that's expressed as VO2 peak, so the oxygen uptake at the end of that graded exercise test. So you can see in this graph that the different studies were at different time points after stroke. important to know is that at this level, so at this level of VO2 peak level, we know that people are at risk of losing their independence. And you can see that the stroke survivors in most of the studies are under that level. So most stroke survivors are at risk of losing their independence. So it's a big problem in stroke survivors' fitness levels. So what can we do about it? Can we actually train people and improve their fitness levels? So as I mentioned before, there was a recently updated Cochrane review done by Saunders, and it was published in 2016, and it included 58 trials with over 2,500 stroke survivors included in these trials. So if we have a closer look at these trials, these 58 trials, you can see that the mean age across these trials, the average age, was 62. So it's a bit younger than your average stroke survivors that you see in hospital. The other thing that you see in this table is that the time since stroke in these trials had a very broad range. So there were people in the samples of stroke survivors were all very early, 8.8, and they ranged all up to 7.7 years after stroke. The level of ambulation, here you can see that most of the studies included only stroke survivors that were able to walk, and the sample size of the different studies was in general quite small. And then the last bit of this table, you can see that in this review they separated the different types of physical fitness training into cardiorespiratory training, resistance training, and mixed training, and most of the trials looked at cardiorespiratory training. For this review, the primary outcome that they looked at was case fatality, so death of all causes. And in general, the number of deaths in these studies were very low. So they took 2 time points. So before the end of the intervention, there were 13 deaths across the trials, and they were evenly distributed between the two groups. And at the end of follow-up, for the studies that had a follow-up period, there were 9 deaths across the different trials. So the numbers were quite low. So it's very hard. It seems that physical fitness training seems safe, but it's very hard to make any strong conclusions about this because the numbers are very low. The other primary outcome or main outcome in this Cochrane review was disability. So not every study used the same disability scale. So if we go to the results, it's a combination of different scales. And again, they looked at this outcome for the different types of interventions, so cardiorespiratory fitness training, strength training, or mixed training. So there we go for the first part of their disability outcomes. So cardiorespiratory training versus controls. They looked at the intervention and separated them out in studies that had the intervention during usual care. So cardiorespiratory training was given in combination with usual care and compared to usual care on its own. And there were 4 studies that looked at this. So in this forest plot, on the left-hand side, you see the 4 studies. Then you get some information about how many people were in the trial, and you can see there were quite small numbers. And then here is the interesting part where you can see this vertical line. This is the line where if the estimate between the 2 groups is 0, there is no difference between groups. And you can see on the individual level of the studies, they all lie on the right side of the vertical line. So there is an indication for that cardiorespiratory fitness is effective in decreasing disability. And if you put all these results together of all the trials, you can see that that's the case. So again, keep in mind that this is a summary result of different disability scales, so it's very hard to interpret, but there is a significant difference between groups in favor of cardiorespiratory training. If we then move on to, as I said, they looked at when the intervention is given during usual care. They also found studies that gave the intervention, so in this case cardiorespiratory training, after usual care had finished. So in this forest plot you see there's 6 studies, same thing, quite small samples, but you see at the top estimate that again there is a significant difference between groups in favor of cardiorespiratory training when you look at the outcome disability. And then this bottom estimate is the estimate where we put these studies together with the studies after usual care. So they pull all the data of all the studies that looked at cardiorespiratory training, and we see a significant effect there on disability. So apart from looking at cardiorespiratory fitness training, they also looked at strength training versus control and mixed training versus control. As I said, the number of studies that were included were the majority were looking at cardiorespiratory fitness, so there's limited information about the effects of strength training on the outcome disability outcomes. So we can't make any conclusions, or this review couldn't make any strong conclusions about the effect of strength training on disability. And for mixed training, they found a small effect at the end of the intervention in favor of mixed training compared to controls. For all of the interventions, strength, mix, and cardiorespiratory training, at the end, at follow-up, so not all studies looked at a follow-up, but that difference and that effect disappeared at the end of follow-up. So the effects didn't sustain after a period of time. So I just discussed the main outcomes of the review, but they also looked at other outcomes. So they looked at adverse events, vascular risk factors, physical fitness, mobility, function, quality of life, and mood. And for most of the outcomes, there was not enough information, and we can't say anything about the effect of physical fitness training on these particular outcomes. But there were some that were significant, showed significant effects. So for cardiorespiratory fitness training, you saw that they had a positive effect on VO2 peak, so in fitness levels, an increased level of fitness in favor of cardiorespiratory fitness, and an increased level of mobility. For strength, for strength training, it showed an improvement in strength, but mobility was not significant. And for the mixed training interventions, you see that there's an improvement in mobility and an improvement in function, and in this case it was balance. So just to put this into context of what was actually found in this review, I think it's important to note, and because this is also my area of interest, there were very, very few studies that actually looked at physical fitness training early after stroke. And most of the studies looked at the intervention after usual care. Most studies included ambulatory participants, so they were able to walk, even though we know that more than half of stroke survivors are unable to ambulate in the first month after stroke. So we can't just generalize this to the whole stroke population. And it is unclear what the effect is on cardiovascular risk factors, so things like hypertension, cholesterol, which would also be interesting to know, because that gives us an idea about if we can prevent recurrent strokes. So the conclusions of this review, just to summarize, is that cardiorespiratory fitness training and mixed training reduces disability after stroke. Cardiorespiratory training improves aerobic fitness and mobility, and there's good evidence to suggest that cardiorespiratory fitness training and mixed training, where walking is involved, should be incorporated in stroke rehabilitation programs. And I haven't talked about this specification where walking is involved, but in the earlier slide you saw that most studies included patients that were actually able to ambulate, and in these studies the modality of the exercise was in general walking. So it seems that the conclusion is that where walking was involved in the intervention, that's where we saw the effects. There's limited evidence for the use of strength training, so that's something that needs to be further explored, and further trials are needed, as always, and in this case they are needed to determine the optimal content of exercise prescription and identify any long-term benefits. Because even though we know that there is that physical fitness training is effective, so cardiorespiratory and mixed training, we actually don't know what the intensity should be, what the frequency should be to have an optimal outcome for stroke survivors. So there are some recommendations and guidelines how we can exercise people after stroke or stroke survivors. So this is taken from a paper from Billinger, and what the recommendations are in that particular paper regarding cardiorespiratory fitness and improvement of cardiorespiratory fitness is that you should train between 55 and 80% of heart rate max. So where heart rate max can be calculated by 220 minus the age of the individual, or an RPE of between 11 and 14, where the RPE is measured on a Borg scale, and it is a rating of perceived exertion. So you ask people to point out on the scale that goes from 6 to 20 how hard they are working while doing the exercise, and 6 is no exertion at all, 20 is maximum exertion, and so you want people to work between light to somewhat hard. Regarding frequency, it is recommended that it would be between 3 to 5 days a week, so preferably every other day, and the sessions take about 20 to 60 minutes, and where they also state that you can break it up into 10-minute bouts. So I would like you to just think about in your own clinical practice, how would you incorporate fitness training in your practice? How would you do it? Would you do it? And do you have enough information to actually start an exercise program for the stroke survivors that you work with? And if you're not a therapist, would you recommend people to exercise after stroke? And sorry. And so, could you, sorry, if you have any ideas, please type in your responses. I'm not looking for the best answer or that there is a right answer, but it's just for me also to think about how can we do this, because we have all this evidence, and how can we implement this in clinical practice. So it would be great if you could come up with your ideas. So I'm interested in what you think. And I'm also interested in what you think, because it seems that we have some guidelines, but if we look at some of the studies that have been done looking at physiotherapy, for example, this is a study that's been done in 2006, and they selected a group of stroke survivors that had physiotherapy, and they observed their physiotherapy sessions and recorded the time spent in different activities, and also recorded the training intensity related to heart rate. So on the left side, you see the graph of the time spent in those different activities that they specified. So looking at standing activities, stepping, basic walking, and advanced walking. So the group of stroke survivors that they included, they separated out in people that were able to walk and people that were not able to walk. And if you look at the time spent in all these different activities, on average, they spent less than 10 minutes on each activity. So even for the walkers, advanced walking was, the time spent in advanced walking was less than 10 minutes on average. If we then look at the right side of the screen and look at the actual intensity during these activities, where the dotted line is the cutoff point that they set. They say in this study 40% of heart rate reserve is actually the intensity that you need to work at to have a cardiorespiratory training effect. And you can see that on average, these people during their physiotherapy sessions do not reach that limit. So they're not at the level to improve their cardiorespiratory fitness. So this study was done in 2006, and a similar study was done more recently in 2014, where they had a similar setup, but instead of looking at one training session, they looked at 2 training sessions per participant. And what you can see is a similar trend. The total session time was 44 minutes on average, and the intensity was 24% of heart rate reserve. And they break it down in the different activities where they added lower limb and upper limb activities. And spending time in those activities actually reached over that 10-minute duration. But again, none of these activities actually reached the level that you want to improve cardiorespiratory fitness or fitness levels. So why do they not meet the criteria? So there can be different answers to this question. There's many factors why people don't train at that level, or that therapy is not at the level that we want to improve cardiorespiratory fitness. So this is where I start talking about my PhD, because I was interested why that was. And I was specifically interested in the idea that was suggested in the literature that it is harder for stroke survivors to be physically active. So for stroke survivors, they have to put more effort in to do the same thing if you compare it to healthy people. So I looked at effort, or the energy that people use while walking in this case, and you can look at that in different ways. So if we talk about energy demands of walking, I was interested in looking at the oxygen consumptions while walking, and you can look at energy expenditure, where you look at the oxygen uptake in milliliters per kilogram per minute, so averaged over the time that people spend walking, or the energy cost, where you look at oxygen uptake in milliliters per kilogram per meter walked. Additionally, I was interested in steady state activity. So steady state is where during an activity there is a balance between oxygen uptake and oxygen use, because when you get in that state, you can sustain that activity for a longer period of time. So when you think about physical fitness training, and especially cardiorespiratory fitness training, that's the sweet spot that you want to train at under those conditions. So on this side of the slide, you can see that at baseline, so when somebody is resting, that blue line, you have specific energy demand. So there's oxygen uptake at a baseline level, at a resting level. Once you start moving, the energy demands go up because you engage more muscles and they need to be provided with oxygen to get the energy. So oxygen consumption goes up, and then at some point you reach a steady state where the oxygen consumption meets the oxygen demands. And that's what I'm interested in. So walking under steady state conditions. So the first project that I've done for my PhD is looking at these energy demands after walking in stroke survivors. And first I looked at the literature. So I've done a systematic review to determine the energy expenditure and energy costs, so both of those measurements of walking after stroke. Just looking at stroke survivors and see if there's any big differences between the different studies and between the different times after stroke. But also to determine if it is true that the energy expenditure and energy cost of walking is higher after stroke, to see if it is actually more effortful for stroke survivors to walk compared to controls. So a systematic review, that's what I've done. I've searched different databases up to October 2014. So this is a systematic review that's been published in 2015. Apart from other inclusion criteria, one of the most important, I think, to point out is that we wanted to only include studies that actually measured oxygen uptake using a metabolic card, where a participant is wearing a mask, and that allows for the measurement of gas exchange while somebody is doing an activity. So these are the characteristics of the studies that I've included. So when we did the search, we found over 2,000 records. We screened all those records. Of those records, we found 144 records that were of interest, got the full text, screened those, and 29 studies were included in this review. Of those 29 studies, 9 studies actually had a control group included in the study. So that's the differentiation between those columns. Again, to point out, the mean age of the stroke survivors in these studies were between 40 and 60 years of age. So again, that's lower than the average of the age that we normally see in clinical practice. Interestingly, again, this is my focus, there were no studies early after stroke within the first month, and the majority were actually over 6 months post-stroke. They looked at different walking modes, overground, treadmill, or both, and just for the interest of this webinar and time-wise, I will just focus on steady-state overground walking. Okay, another forest plot, because I like forest plots. The first thing, as I said, that I wanted to look at is what is the energy expenditure of steady-state walking post-stroke, just looking at stroke samples in studies. And I divided them in studies that looked at stroke survivors that were between 1 and 6 months post-stroke, and the other studies that were including stroke survivors over 6 months post-stroke. And you can see, even though there is a bit of a shift in energy expenditure, they are very similar, around that 10 mils per kilogram per minute of oxygen uptake. So how does that compare to controls? So of all those studies, there were only a few studies that we actually could pull together, but I think this is giving a nice picture of what is actually happening. So again, first I looked at energy expenditure. So this is looking at oxygen uptake averaged over the time spent in that activity. So most of the studies looked at a walking task of a 5 to 6 minute walking task. And at the top of this graph, you see two studies that looked at overground walking. They included participants between 1 and 6 months post-stroke, and they asked stroke survivors and healthy controls to walk at a self-selected speed, so a speed that they felt comfortable at. Interestingly, you see that the squares lie at the left side of the line, indicating that energy expenditure of stroke survivors is actually lower than controls. But in one of those studies, they also did the same task, walking task, but then asked for the second task to have the controls walking at a match speed to the stroke survivors. And what you then see is that stroke survivors actually have a higher energy expenditure compared to their controls when the controls walked at the slower speeds, matching the speed of stroke survivors. So in this next one, we look at energy cost. So in energy expenditure, you don't take walking speed into account, but with looking at energy cost, you do. You look at the oxygen uptake per meter walked. And then those are the same studies. If you then look at energy cost, you see why it is important to take walking speed into account, because then you see that per meter walked, the oxygen uptake in stroke survivors is higher than controls. So what does this mean? So it appears that the energy costs, so the efforts of stroke survivors to walk, are higher compared to healthy controls. But we actually don't know if that difference is actually of clinical relevance. Is that difference big enough to make a difference on the level of the individual? So it is important to take walking speed and distance into account, because if you look at energy expenditure, it seems like it's suggested that it is not more effortful for stroke survivors to walk, but if you look at per meter walk, you see that it is more effortful for stroke survivors. There is a lack of studies in acute stroke, and the majority was looking at included stroke survivors over 6 months post-stroke. And again, there were mostly younger stroke survivors than the people that we actually see in clinical practice, because we know that 69% of people who suffered the stroke are aged over 65 years or older. So this systematic review really led to the observational study that I've done, that because we wanted to look at the energy cost of steady state activity early after stroke. And it is activity because we wanted to include not just ambulatory stroke survivors that we see that been included in most of the exercise study. We wanted to broaden the stroke survivors in our study so that we can have a better idea of the energy cost of people that are actually not able to walk. And we focused on steady state because, again, steady state is important for our exercise mode when we start thinking about improving cardiorespiratory fitness. And we also wanted to determine if there is a difference in energy cost between stroke survivors and healthy controls early after stroke, so in the early stages. So we recruited stroke survivors and healthy controls. We asked them to walk 6 minutes if they were able to walk, or do a 6-minute sit-stand if they were not able to walk. And for our controls, they did both those activities. So during those 6-minute tasks, they were set up with an Oxycontin mobile, which is a metabolic cart, and you can see from the picture people wear a mask where we measure their gas exchange, which gives us a measure of oxygen uptake. So we were interested in energy cost, but first we wanted to see if our stroke survivors were able to reach a steady state. So our definition of steady state was that there was less than 2 mils variation in oxygen uptake per minute in the last 3 minutes of the 6-minute walk, because people need to get up to that level where there is a balance between oxygen uptake and oxygen demands. And we looked at the difference in energy cost of that steady state period between stroke and healthy. Okay. So we included 13 stroke survivors that who were able to walk. We had 7 stroke survivors that performed the sit to stands, and the controls, we had 10, and they performed both activities. You can see that the age is a bit higher than what is normally seen in exercise studies. What I really would like to point out is that we actually had them quite early after stroke. Even though we said within 3 weeks after stroke, we were able to test them in the first week after stroke. The other thing, though, is that most people had mild strokes. So that was our sample. So the first thing that we wanted to check, as I said, is were they able to reach steady state? And I would like you to focus on those red lines, because those are our stroke survivors, and you can nicely see that their oxygen uptake goes up at the beginning of the task and then nicely levels out from the 3-minute mark on. So we can see that our stroke survivors were able to reach steady state. So they are able to actually do steady state exercises. And then we looked at the difference between energy cost of the stroke survivors and healthy controls. So first of all, we look at the walking task, and you can see that every dot is one individual, and the red lines indicate the average of energy cost within the group. You can see that there's a lot of variation within the stroke group and less variation in the healthy controls, which is not really surprising. We know that the stroke survivors that we see have a lot of variation in their fitness levels and in their capacities. And you can see that the difference here, or that there is a difference between healthy and stroke, and that difference was significant. We then look at the difference in energy cost of sit to stands stroke survivors compared to healthy controls. Again, you see a lot of variation within the people who had a stroke, less variation in healthy, and the difference between the energy cost between the two groups was not as big as in walking and was not significant. Well, what does this mean? So we've seen that the energy costs are higher, especially in walking after stroke. We can't say much about the sit to stands, but if we translate this back to the recommendations of exercise, the intensity, if we look at the recommendations for VO2 reserve, which is a different measure of intensity, but they're all related, it's recommended that to improve physical fitness or cardiorespiratory fitness, people need to train between 40 to 70% of their VO2 reserve. So what's the VO2 reserve? VO2 reserve is VO2 peak minus VO2 at rest. So if we all think back, I hope you can remember, if not, I'll just say it here, the physical fitness levels, or the fitness levels, cardiorespiratory fitness levels of stroke survivors in that systematic review at the beginning of my talk ranged quite a lot, but were very low. So the range was between 8 and 22 mils per kilogram per minute, expressed as VO2 peak. And we know that the VO2 peak at rest in general is about 3.5 mils per kilogram per minute. So if we then take the most fit level of our stroke survivors and see if they meet those criteria of 40 to 70% VO2 reserve, we say 22 mils per kilogram per minute for our fittest stroke survivors, so their VO2 peak minus the VO2 at rest, and then 40% of that VO2 reserve gives 7.4, 70% is 13. So in the study, in the observational study that I've done, the VO2 during steady state walking was 9.5, and the VO2 in our stroke survivors during steady state sit-to-stands was 8.2. So according to these numbers, it is possible for some stroke survivors to actually get to that level of intensity to improve their fitness. So it is possible to train people early after stroke. And keep in mind, these people were just 1 week after stroke. So to conclude, stroke survivors, ambulatory and non-ambulatory, can reach steady state activity. Although it's true that acute stroke survivors require more energy per meter walk, it doesn't mean that they can't reach a level of of intensity of training to actually improve their fitness levels. But we don't know what the actual intensity is, again, and we don't know how many times per week they need to train, what's the safest intensity. So therefore, one of my other studies that is underway at the moment is looking at finding out what the maximum intensity is that people can train at early after stroke. So just to go back why it is so important, cardiorespiratory fitness can help in the prevention of cardiovascular disease. It might be able to prevent recurrent stroke, and it can have an influence on some cardiovascular risk factors. So if we then go back, we know that the fitness levels are very low after stroke, so it is important to see if we can actually improve it. So if we think about what improving fitness levels can lead to, and that it can help to treat some of the cardiorespiratory cardiorespiratory risk factors, so as again looking at hypertension or cholesterol, maybe we should look at exercise as a medicine. And that's how I got to my last study, or the method of my last study. Because we know if, for example, there's a new drug on the market or developed for cancer, one of the first stages to test if this drug is safe is looking at it through a dose escalation study, where they include 3 patients and they get the starting dose. If all those patients are fine, they don't have any adverse effects, then another group of 3 patients will be included, and they go on until some of these patients get adverse effects. And there are strict rules about how many adverse effects and which adverse effects are the ones that make the study stop. So they could say if 2 of the participants get this adverse effect, then we include another 3 and they get the same dose. But if it seems that that's too toxic, there's too many adverse effects, then you know that your limits are reached, and that's the maximum intensity of that particular drug, or the maximum dose of that drug that is safe. So as I said, we know that it seems possible for people early after stroke to engage in cardiorespiratory fitness training, but we don't know what the maximum safe intensity of the training is. So why can't we do that in exercise studies? So there's a lot of variation, as we've seen, in fitness level and energy expenditure in stroke survivors. So what I'm suggesting is that we look at people with low exercise capacity after stroke and moderate exercise capacity, and we do the same thing. And because of this variability in stroke survivors, instead of looking at 3 per group, we look at 5 participants per group. And we go through the same process. So, as I said, there are strict rules about dose limiting events. And how we set it up is saying, so the red ones are the people that had an adverse effect. So if 2 out of the 5 had an adverse effect, we still think that that particular dose intensity is safe, and we escalate the dose and we include another set of 5 people and go with a higher intensity of training. If 3 out of 5 have an adverse event, we stick to the same dose and try that intensity in another group of 5 people, and then see if we should escalate or if we should stop the trial. And then we stop the trial if there's 4 out of 5 that actually can't do the training or have adverse effects. So that's the method of the study. So as I said, the study is still underway. So to check in what the participants' exercise capacity is, they do a graded exercise test at the start of the study, and then they will be put in or the low exercise capacity or the moderate exercise capacity group. And then in both groups, they first go through a adaptation phase where they get familiar to the exercises over a 2-week period, where they have 3 sessions per week with aerobic training and a bit of strength training 2 times a week. And then in the second phase, we actually work at the target intensity that was predefined before the study. So they work at a percentage of their heart rate reserve for 2 weeks, 3 sessions per week. And then we monitor their dose limiting events. And so depending on how many people get a adverse event, we escalate the dose in a new set of 5 participants. So these are the dose limiting events. I won't get into them now. As I said, the study is still underway. So far, we've recruited 10 participants. We had 4 participants in the low exercise capacity, 6 in the moderate exercise capacity group. 7 have actually completed the training program, and it's looking good so far, so we can escalate to the next group. 3 participants of those 7 are in the low and 4 in the moderate. So as I said, it's still ongoing. Hopefully I'll finish this at the end of this year and it can go into my thesis. That will be great. Yeah, so to conclude, I think what we've seen is that we actually can train people after stroke, and it is important to improve cardiorespiratory fitness after stroke, but there's still a lot of questions, especially in those early stages, and I hope with my PhD that I can shed some light on some of these questions. So thank you for attending, and I can take some questions now.
Great. So thank you, Sharon. I think you've certainly opened a really interesting discussion for all of us to be thinking about what training opportunities there are for our patients. Just at a general level, exercise as a therapy is becoming a really common theme amongst a whole range of clinical areas. And I know that certainly in cancer, exercise physiologists are leading the way in that space. Who do you think should be supporting this intervention at a clinical level? Should we be getting more exercise physiologists into the rehab team? Should it be physios? Is there a difference between who leads that work, and what are the advantages and limitations of all of those scenarios?
Yeah, I've been talking about this a lot with one of my supervisors, Liam Johnson, who is an exercise physiologist, and to me it seems that it would be good at this moment to get exercise physiologists involved in stroke rehab, because they have really good knowledge about how to train people and actually get to that level of intensity. Yeah, so I think it's a good match to have physiotherapists and exercise physiologists really come up with a good plan to make that part of clinical practice and make that part of stroke rehab.
Great.
I think that's very important.
We will ask people as we continue on through the questions, if you could please fill in the feedback form while we're talking, and if you've got any other questions, please do add them to the blog and we can talk about them now. So early on in the talk, especially when you're going through the systematic review, Liam posted a question talking about the case mortality and was wondering, was the control group a non-exercising group?
In the control group of so they divided it into interventions during usual care. So some of the control groups got usual care, and there might be some component of exercise in there, but all part of usual care. And then in the other group where it said after usual care, there was a match of another intervention. To my knowledge, it wasn't exercise or an exercise component in the control group, but I need to check if that was the case for all of them. But
group therapy option or something like that, just to sort of.
Yeah.
Okay, great. And you also mentioned on the back of some of that research that in the follow-up, very few of the interventions, or in fact none of them, had a sustained impact. So what does that tell us in terms of the efficacy of the treatment and how much bang for your buck you're getting if there's no sustained impact?
Yeah, I guess, so if we take away stroke completely, if you stop exercising, your fitness levels will drop. If you stop your strength training and you don't sustain it, you will see that there is a drop in your strength. So this is my view. I don't think that that's different in stroke survivors. So we have to think about how we can make the effects that we get sustainable over time. Instead of just giving them an intervention over a period of time, how can we make lifestyle changes so that they can incorporate this in their normal daily routines? I think that that's, as a physiotherapist, that's always a challenge. Even when you say, I want people to exercise, to get them exercising during the time that you have contact with them is hard enough. And to have people exercising after the intervention has stopped or after your therapy has stopped, that is the challenge, I think. I have to make a note, though, because in that Saunders review, there were a few studies that actually looked at long-term follow-up after the intervention had stopped. So we really need to invest or investigate more how those effects last and how we can make them last over time.
We went on then to talk about, or you asked the group, what are some of the interventions that people are using to support stroke survivors with exercise. And some of the suggestions that have come through are from Bridget, and she's said that they're using a MotoMed, a seated exercise bike with a motor option. And Sarah has suggested they're using stationary bike training and swimming, following a swim training, safety training with physio. And they're also using recumbent bike riding. And all of these options are sort of, I guess, more technical options than your suggestion of sustained walking. So what's your view about that, and do you have a preference for what do you think the optimal form of exercise might be?
I think when you think about exercise, and this is also about getting people motivated, you have to find an exercise that people are comfortable doing, that they are able to do. So, I think it's good to think about different modes of exercise that allow people that that are not able to walk, that they can still exercise. But we have to keep in mind that with all these different exercises, you need to get to a certain intensity to actually have an effect on your cardiorespiratory fitness. So coming back to finding a mode of exercise that people are comfortable doing also makes it easier for them to sustain it over time. So when your therapy stops, that they are still motivated to keep going with those exercises. So I think it's very important to find find that particular interest of your patient, and to encourage them to keep going with that.
And you talked also about the fact that in the Cochrane review, a lot of those studies started after usual care had finished, but your studies are looking at patients more early, and in some cases as early as 4 days post-stroke. So Jessica's asked, is there any guidelines about how soon after stroke patients can resume cardio exercise?
Yeah, the recommendations about exercise after stroke is quite broad and not very specific. So in general, they say as soon as people are stable, medically stable, you can start exercising. So the lower limit is, for example, the 40% of heart rate reserve, and that is quite a low level of intensity. And that's what we're working at the moment with the stroke participants that I've had in the study. So that is doable, but we actually don't know how early and how intense the exercises should be to be safe. So that's really what I focus on in that last study. So there are not really clear recommendations, and we don't know much about the safety after stroke.
And I think that sort of leads into Sarah's question, where she's asking about what measures are you using to determine low versus moderate intensity exercise, and what's the duration for each session?
Okay, yeah, so when people come into my study, they all get a graded exercise test, and we use the protocol that was developed by Sandra Billinger, or is it Sandy? I always forget. In the US, and she's done a lot of exercise test types of studies in stroke survivors. So we use that protocol where people get a graded exercise test on a recumbent bike. So it's the same setup. Their workload goes up every 2 minutes, and we measure their VO2 peak. So the VO2 peak, according to their VO2 peak, they get into low or moderate exercise capacity. Once they get into the training stage, the intensity is decided by their heart rate reserve, so a percentage of heart rate reserve, where you look at the heart rate max, so that's 220 minus their age, minus the heart rate rest at the time that they are in the session, and then take a percentage of that. And we monitor their heart rates every minute during those sessions. So to make sure that they actually reach their target intensity, because that's the aim of the study.
Yep.
I hope that answers the question.
Yeah, and I think that's also feeds in a little bit to what Liam was saying before that, which was, are we being too prescriptive with our exercise? But it actually sounds like we're tailoring the exercise very specifically to the individual's needs, to their workout capacity, and then maintaining that level of desired output for a period of time. But that actually requires a great deal of monitoring, and the question is, how realistic is it to transfer that paradigm into a clinical environment where you might be seeing multiple patients at once, and you know, it's a very challenging thing to do that intensive monitoring and tailoring, which I think that brings us back to, again, perhaps using additional therapy staff or disciplines like exercise physiologists to support us in this goal of being able to provide targeted exercise therapy in an appropriate way for in an individualized paradigm for each patient.
Yeah, and that's exactly why I asked that question earlier on. You know, it's fine that we know that the evidence is there to start cardiorespiratory training in stroke survivors, but how do you actually do that in clinical practice? Because, well, as you can see with our study, we measure it very intensively, and that's not feasible in clinical practice. So how would we do that? I think there are ways. So heart rate is not a difficult thing to monitor along the way. Maybe not every minute, but maybe every 5 minutes, or every time that you say, well, we want at least a 10-minute bout. What is the heart rate at the end of the 10-minute bout? That might be a model to incorporate in your clinical practice. I think RPE, I think Sarah mentioned RPE is also something that you can use to actually gauge how hard people are working to get a bit of a level. So it seems that RPE levels are correlated to heart rate intensity. So that might be a model to use in clinical practice too, that is easier to incorporate.
Look, well, thank you so much, Sharon. That's been a really great session. And again, to our listeners, if you could please make sure that you do complete our feedback form and provide us with any input or suggestions you have for future sessions, would be very much appreciate that. Next month, I think we have Sharon Teese talking about ways to improve participation post-stroke, and I'll be sending out information about that hopefully in the next week or so. So thank you to all our listeners and our participants today. We really appreciate you tuning in. Please do fill in the feedback form, and thanks again, Sharon, for a great session.
You're welcome. That was great. Thank you so much.